Welcome to the Proactive Security Podcast with Mike Hodges and Brine Hamilton. This podcast is dedicated to discussing violence prevention in healthcare. We want to inform, equip, and empower healthcare security leaders to prevent violence before it happens. And now, here's your hosts, Mike and Brine.
Hey everybody, I'm Mike.
And I'm Brine.
And this is the Proactive Security Podcast, Episode 3.
And on today's episode, we're going to be discussing leadership engagement.
Leadership engagement is a critical topic, Brine, because as you know, and as I know in healthcare, if you don't have your leadership tied into an issue and really connected and communicated well with and understanding the issues you're dealing with, you're not going to get anything done.
Absolutely. Now, in terms of leadership engagement, I guess the first thing we'll touch on is the ownership. So who really takes ownership? And I ask facetiously because I know your answer, but who takes ownership of the workplace violence prevention program?
You know, this is an interesting concept for me, and you talk about ownership, and I think ownership is so critical when it comes to violence prevention, especially in healthcare. But when it comes to workplace violence, if you look across the industry, there is no collectively understood owner of that program. You look elsewhere in a healthcare organization, you'll find areas of interest that own certain things or are owned by certain groups. But workplace violence has always been a little bit of a stepchild as people have shuffled it from one area to another. And so, you know, in some facilities you see human resources owning workplace violence prevention. In some facilities, you see nursing owning workplace violence prevention, or security owning workplace violence prevention, or some other ancillary group that has some tie into it in some ancillary way. But the truth is, and I think this is a key point, is that it is a core responsibility of healthcare security professionals. And if we're going to tackle workplace violence prevention well and really tamp down the acts of violence against healthcare workers, we as healthcare security leaders have to own that, not only individually at our local entities, but professionally at large as a subset of the healthcare security industry. So I think that's huge.
All right, Mike. Now, as you mentioned there, not every hospital runs it the same way. It's not always security who's in charge of workplace violence prevention. A lot of times it's other areas, and for various reasons. Now, as a healthcare security leader, what can we do to really take ownership of that program if it hasn't resided with security in the past?
I think there's a few things you could do, Brian. I think the first thing is one, you've got to educate yourself. I mean, if you're going to be the owner of workplace violence prevention, then you need to be the expert on workplace violence prevention in your facility. If you don't understand that topic fully and conceptually well, then you're going to have struggles when it comes to convincing other people that you know what you're talking about and that you should be in charge of that issue or owning that issue. Two, you really have to build really cross-organizational and cross-discipline collaboratives. You've got to start pulling other people into the discussion with you. And a big part of that is educating those people to start with. So you can't just hold a meeting and tell everybody this is important and we've got to have everybody involved in it. You really have to do some education on the front end with those folks from across the organization, from across other areas of concern within the organization, and lead in a way that allows them to understand why this topic matters and how they can plug into it. Because I think a lot of people shut down when it comes to workplace violence because it's such a big kind of amorphous topic that covers so many different things. All of them are hard, all of them are ugly, and nobody really knows how to wrap their arms around it. And so you setting yourself up as the expert on it in your facility through your own personal education and pursuit of learning on the topic can really start to build those cross-organizational and cross-discipline collaboratives by educating people about the topic and making them feel comfortable to engage with the topic so that you can start to pull information out of their subject matter expertise. And I think that's a huge piece of that. So those two things kind of work in tandem when it comes to owning the process and moving the ball forward. I think From an industry perspective, security professionals in general and security professional groups, more specifically, when you look at like IHSS or ASIS or some of those other larger, security professional groups, have to start owning it as well, right? It can't just be us as individuals in our facilities. We need larger collaboratives within our own industry to help draw from as we seek to educate ourselves. And I think this has been one of my biggest frustrations is our lack of engagement at the professional group level. And so, starting to identify centers of excellence, starting to point to best practices, starting to pull together knowledge resource centers so that people like you and me who are out on the front line in healthcare security can go to those groups and tap into that knowledge and identify opportunities to continue to educate ourselves and then take that back to our organizations as we build those cross-organizational, cross-discipline collaboratives to work on this issue.
Excellent. Now, another thing that we want to touch on is just the oversight of the actual program itself. Another important piece of that obviously is engagement. So who are the key leaders that we want to engage in a workplace violence committee?
So as you're building those teams, I think there are four key executive positions that come to mind that you really want to tap into, and it's obviously your COO, Chief Operating Officer, your CHRO, your Chief Human Resources Officer, your Chief Nursing Officer, your Chief Medical Officer. Those four executives would be the four executives that I want to tap into the most when it comes to building workplace violence prevention teams, because their oversight is going to be comprehensive when it comes to the types of individuals you need to engage in changing policy and changing procedure and changing training and changing culture within your organization. And those are all things you're going to have to tackle at some point or another as you're building a workplace violence prevention program. So those are the four key executives. Beyond those, you know, tackling in someone from your quality improvement department and leveraging their key ability to access data analytics metrics within your organization is critical. Pulling in somebody from clinical education to help you navigate the education of your clinical partners, pulling in someone from employee relations or employee health and safety to help you tackle critical victim follow-up and having the appropriate amount of follow-up actions and key resources needed to support those individuals who do experience violence in your facility. Those are all other areas that you can tap into. And of course, nursing leadership at all levels, which I already mentioned the CNO, but pulling in key nursing leaders within your facility, your risk management professionals, all of those type folks are critical to pulling in a comprehensive collaborative group that's going to be able to help you navigate the whole organization well.
Excellent. And what would be what's a good cadence to engage with these leaders? I know you obviously want to make sure that you're not you want to make sure that you keep their attention, but what's too much versus not enough? Where's a good middle ground?
Yeah, so I think your regular engagement is really important. Obviously, this is not a fire and forget kind of issue. So you can have a big launch meeting and everybody gets all spun up and excited, and then you don't ever do anything for follow up. That's gonna die on the vine. What you really want is a constant rhythmic engagement, and so I have found monthly or quarterly is probably most effective. If you really want to keep your senior executives engaged, then quarterly is more appropriate because they're busy folks. And if you try to tackle it more than that, you're probably going to lose their attention or burn them out too quick. But having that regular rhythm, quarterly is what we do at my facility, which works very well. And in that engagement, you want to constantly share information. And so I'm all about having a set pattern of data, defined data to share and present, along with the kind of key measurable metrics associated with that data. So when you're talking about what information you're going to cover in your regular engagement with executives, I'm always about having some type of metrics program established so that you can show measurables. that not only speaks well to the executive folks who want to understand what's the true on the ground information, but two, it helps you tell that story more effectively. You drop away the facade of anecdotal information and get to the bare bones of what's actually occurring in your facility, and then you can attach those real numbers to the human stories and the human elements that make workplace violence what it is, and helps you explain it effectively so that you can continue to create ownership in the entirety of the group as they look at that.
All right, and as far as data collection and reporting, obviously the metrics are a big thing that you touch on. What are some of the key areas of focus for you? Because I know there's so much data that you can gather, and there's so much rich information that we can get. What are you really focusing on in this engagement?
So, for us, we look at a couple of key measurables. So we look at, yeah, obviously actual assaults. So anytime there's actual physical altercation, we look at those numbers. Then we look at what we call workplace violence indicator events. And so when we talk about workplace violence indicator events, we're talking about incidents that involve a measure of violence, but not actual assault. So they're more indicative of the potential for violence in an organization as opposed to the actual level of violence in the organization. So this would be your calls for disorderly conduct, your calls for threats and harassment, verbal threats and harassment, calls like that that are ancillary to actual violence, but they're not actual violence themselves. And so all of that falls within the auspices of workplace violence. If you look at the traditional OSHA definition, which is all any act or threat, so any physical act or verbal threat of violence. But they give you kind of a breakout so that you understand the differentiation between what's the potential for violence in the environment versus what's the actual violence in the environment. And I think one of the key things is you taking that information and you're showing that data trended over time. You're showing information relevant to what we're seeing. One of the things we really like to do is break out key assailant characteristics. So what are the key characteristics of those individuals who are assaulting our staff? And so, can we aggregate over time as we look at those people who have committed assaults? Is there a common age range? Is there a common medical diagnosis that's associated with them? Is there a common, what are the commonalities that we can look to give us pre-indicators for potential violence? And use that information to then spur education, right? So all of it, everything you present from a data and metric standpoint to your key executive leaders as you engage leadership in general is designed to help you drive change. So, what are we trying to change? Well, we're trying to impact policy. We're trying to impact training decisions. We're trying to impact the way we care for our patients, both from the clinical bedside nursing perspective and from the medical provider perspective. And so, we look at what's the information we're seeing, and then how is that information translating into active change we can make in the environment that we can then continue to measure through the things we're seeing in our data and through those metrics that we're looking at. So that's kind of the process. That's the flow. We want to see the information, and then we want to drive change through that information and then measure if our changes were effective. So it gives us a kind of a constant feedback loop and full engagement of the executive team in that process, because they too can sit there and say, okay, here's the information. We're seeing how it impacts our staff. Let's make these changes, whether it's policy, training, or the way we're caring for our patients, and then measure those changes and see if we're seeing any improvement.
All right, Mike. Now, obviously, talk about data collection, talk about the changes that's going to drive. I guess what we're really saying here is that the data tells a story. Now, as far as communicating that story, how are you using that data to tell the story?
I think one of the things, and this also ties back into ownership. One of the things I think we have to look at is really changing the perception of security as a ancillary department in a healthcare facility. And I think workplace violence and the data we collect on workplace violence and how we impact that data. So when you're looking at that kind of circular story where we say, hey, you've got information, we see how that information is impacting our employees, we make those changes and we see how that impacts our employees as well through the data. That is a full story of how security enables business within a healthcare environment. And so one of the things that I've really been curious about in the last few months is changing the nature of how we think about healthcare security, right? So as an ancillary department or an operational department, oftentimes we're seen as a cost center.
Right.
The cost of doing business, so to speak, an insurance, if nothing else. We've got to pay the insurance premiums to keep the insurance up, just in case something happens. Which is all well and good. It's a people have been looking at security in those terms for a long time. But I think for us, for healthcare security leaders, one of the biggest opportunities we have, and the data we pull out of workplace violence really helps us with this, is to change the nature of how we talk about ourselves and therefore how we are perceived by those executives we're engaging. And I really like the idea of this term business enabler. And so, a business enabler is someone or something that's able to help the business improve, right? That can identify and instigate changes within the organization to help the business improve effectively. So business enablers cost money. You gotta invest in those enablers to have them function, but at the same time, they're constantly improving your business. And so from that perspective, I think we have a unique opportunity to take data and the data that we collect and the metrics that we measure attached to that data and execute that story about being a business enabler well. And so you got to link yourself to some other measurables, right? So, we can talk, man, we see these many incidents happening with these type people in this location in an organization. Great. Let's change some policy here. Let's tweak this. Let's put some resources in. Now we see those incidents are going down. Well, what does that mean? Well, we just spent some money to make some incidents go down, but does that have any impact on our business? Well, we've got to start linking some measurables to that. And one of the things that we have an opportunity to look at is we have massive impacts on the business when we're looking at workplace violence. When you talk about, OSHA has reports on direct and indirect costs associated with different types of violent injuries. So when you look at like concussions, OSHA has reported that a concussion from a worker compensation standpoint averages around $57,000 per incident. For a laceration, $41,000. For the mental stress associated with violence, $64,000. These are all costs that we can measure in the environment that start linking to how we enable. We stop a concussion from occurring. Well, that's $57,000 the organization just saved. That's business enabling. The Emergency Nursing Association has reported that it costs $82,000 to recruit, hire, and train a new nurse in an emergency department. Well, if we can reduce turnover and increase retention because we've reduced the violence in the environment, well, then we can save the organization that $82,000. That's business enabling. If you look at the American Society of Safety Engineers and the American Nursing Association, figures from both of these organizations, if you put them together, you can estimate, and it's an estimation because we really just don't have solid numbers around this across the industry, but we can estimate that about $1.6 billion annually is spent by healthcare organizations on some form of workplace violence issue, which is an enormous number, right? And anytime we can show through our data what we're doing impacts or chips away at that $1.6 billion, then we're winning. We're enabling the business, right? We're showing positive impact not only on the quality care environment, but on the bottom line. And I think that's a critical thought that we can translate to our executive team, is that violence impacts all aspects of our business, right? It's not just a quality of life standpoint for our employees. It impacts our business, and that's a big deal. And I think you could take that even further and talk about the quality care environment from that perspective as well. But we've got to start telling that story and start really telling people about how we are business enablers, not just some cost center.
Absolutely. And you started touching on some of the impacts of violence and how it really impacts the healthcare as a business. What are some of the things that you see? Like, what are some of the impacts of the increase in violence in the healthcare environment?
Yeah. So, one of the things that really sticks out to me when it comes to that is this whole concept of the quality care environment, right? So we really want to be quality centric in healthcare. We want to create a quality care environment where you receive the best care and the best environment and the best experience. These are the things we're striving for, right? Well, when you're dealing with violent environments, there's some negative impacts. So if you look at reports from the Bureau of Labor Statistics, anywhere there's a perceived violent environment, you're going to see a 7% increase in absenteeism. You're going to see a 6% increase in turnover rates. You're going to see a 9% decrease in productivity. Well, that makes total sense when you think about it, but you can start putting numbers to that. That helps you tell that story more effectively. If you certainly should expect a decrease in productivity in a more violent environment, because if you're scared to death of the patient you're trying to care for, you're not going to be very productive and helpful. That's just not, that's not something we should expect of a normal human being. If you look at data from OSHA, again, this is like the median days away from work as a result of an intentional injury by another person, right? So this is a result of an assault is 7 days. That's an enormous amount of productivity to lose. So when you're talking about a nurse or a patient care tech being out of commission for 7 days, well, there's direct costs associated with that because obviously the injury associated with a 7-day recovery is going to cost your organization a lot of money to pay for from a worker compensation standpoint. But also, we've got to backfill that position, right? So now we have to have somebody that we're paying overtime to or somebody that we're paying, incentive pays to cover that hole in the schedule. So that's going to be an additional cost on top of that. And then you've got the reduced care, right? So if you're constantly seeing people turn over, or if you're bringing new people in to provide care in a specialty area, well, they're not going to be as proficient as that person who's supposed to be doing this job, but is out because they were injured in an assault from another person. So all of those things help us point to the enabling factors that we can provide in the environment. If we can keep people engaged in their job, keep them from being out of work for unnecessary reasons, keep them feeling comfortable and safe, well, then they're going to provide better care. If they feel safe in the environment, if they're comfortable in the environment, if they're not hurt, they're going to provide better care to the patients. So you're going to improve the quality care environment overall for your patients. Healthcare workers, assaults comprise 11% of their total workplace injuries that involve days away from work, as compared to 3% in every other sector, which is just ridiculous that it's that much higher. But it's killing us when it comes to the loss in productivity, the absenteeism, the turnover. I mean, bottom line, violent environments result in decreased employee engagement, poor quality care for our patients, and big dollar costs for our bottom line. And it's just it's one of those things that if we don't start to tell that story effectively, if we don't start to talk about how we as owners of workplace violence prevention can help mitigate those losses to our organization, both professionally by maintaining our staff in a safe environment, and um, you know financially by reducing the loss in dollars. Those are two key areas where we are absolutely 100% enabling the business of healthcare to move forward, and that is how we sell our services effectively.
No, absolutely. And you touched on the decrease in employee engagement, obviously how that impacts morale, and then it puts you in that kind of that circle where you go back to the increase in absenteeism, the increase in turnover, the
Yep.
decrease in productivity. It just impacts all of those areas in a negative way. And then you create a situation where it's difficult to even to correct without taking the appropriate measures. Like, you could always bring in new staff as people are leaving, but if you bring in new people into a bad environment, they're eventually going to take on those same traits, and you're going to it's going to continue, and you're not solving the problem.
Well, yeah, it's incredibly cyclical, and it really is kind of like this spiral of doom. If you don't intercede early and effectively to eliminate that, it just perpetuates itself over and over again.
Absolutely. All right, that's some great stuff, Mike. Is there anything else that we need to cover?
No, I think that really covers it when it comes to leadership engagement. I think if there's one thing that people take away from this topic, at least from my perspective, it is be that owner, right? If you're a healthcare security leader in a facility, whatever level you're at within that facility, this should be a topic that you own without reservation and without apology. This is something that we have to wrap our arms around, both individually as leaders in our facilities, but also organizationally as a profession. If we don't own this, then I don't know what we're supposed to do. This should be our mission and our calling when it comes to healthcare security.
Absolutely, Mike. Couldn't agree with you more. All right, Mike. Well, that's our time for today. Join us again in December when we talk collaboration and communication. And until next time, stay proactive.